Well, hi, everyone. Um, Thank you all for joining another Butterfly POCUS Power Hour. I'm Peter Weimersheimer. I'm an emergency physician. I'm the VP of Education and Clinical Implementation at Butterfly. And tonight I'm joined by my good friend and colleague, Dr. Davinder Ramsingh. Now, we do these webinars every month. Actually, I have my Alberto Giaffi memorial glasses. Not that he's died, but for the first webinar we did, it was in August, over 2 years ago. And we've been having all sorts of topics, and the goal is to support all of you in your journey to use ultrasound for patient care, right? I think we're all here because we understand that the pressures in patient care are time and, frankly, imaging, like how to help your patient, and ultrasound is fantastic for that. And we're going to do something a little bit different. This is going to be fun for us, at least. We're going to go back to the basics. We all started somewhere, and what's been interesting on these webinars is that almost every month there's a lot of comments from listeners like yourselves who ask, boy, I'd love to learn this application, but I just don't know how to start. Or I've used it, but I don't know how to use it for clinical decision making. And the other thing that's been fun is that every week or every month, we ask our guests, what's a pearl of wisdom? How can you inspire the audience? And invariably, they all say the same thing. Scan, scan, scan. You got to scan. You got to do it to you feel comfortable, and you're going to get to that magic sweet spot where what you do with that probe in your hand changes people's lives. And so we figured we'd talk about the basics because everyone starts somewhere. As I can still remember, I was in a place where an ultrasound machine showed up way before they had any type of training. And I had a mentor, and I remember proudly showing him a structure. And he's like, that's not at all
That's
what you
not
think it is. You're
it.
like, dummy. But also, I can still remember after struggling and learning, okay, why am I learning this? And then there's that first case that was I can remember she was a 33-year-old woman. She was in a waiting for 5 hours patient with recurrent gallbladder pain. And she comes in and something's not right. And I get that machine that I've been trying to practice on. And there she has free fluid in her abdomen. She's exsanguinating from an ectopic. Would have been dead in 10 more minutes. And like you get a case like that and you're hooked. Like I need to learn this. And and that's going to be the case for everyone. So all of you, we're thrilled you're here. Please ask questions in our Q&A. If there's an application you've been struggling with or want some feedback on, we'd be happy to talk about it. And probably many of you will hear a question in the audience and you'll have had that same struggle. So you might have a really cool trick of the trade. And by that, when I say we, I'm going to introduce Davinder. Again, Dr. Davinder Ramsingh, an awesome friend, an awesome cardiac anesthesiologist. And Davinder is really good at imaging, and he didn't get there by accident. Davinder could an apical four-chamber view out of a rock. It's amazing. So with that, thank you all for coming. Davinder, please introduce yourself and let's get
Yep.
going and enjoy
Sounds
some
great,
banter
Peter.
on basic ultrasound.
No, this is great. And yeah, thanks so much for setting off this topic, which I think to your point, so great to kind of go back to the basics and say we all started somewhere, right? And if you want to go ahead and start putting up the slides to kind of kick things off, uh, to prepare, we wanted to kind of go with that and start with the basics of how we all embraced ultrasound from the very fundamentals of, okay, you just unbox your ultrasound system or your ultrasound probe. What do you do with it, right? So let's go through the basics. And I want to reemphasize what Peter said, that we all started somewhere. I myself, both Peter and I, trained in an era where we went to medical school, we went through residency training, where POCUS, the idea of handheld ultrasound, the idea that you would rapidly assess somebody to determine what's going inside of them by ultrasound was not a thing, right? We both learned this after those training efforts because of the fact that we saw the clinical value. And I look forward, Peter, to kind of go back to that time and kind of think about what the effort took for us to kind of embrace this. There was struggles along the way, and I think you're gonna, let's kick off into these slide decks. Nice, love your picture here of yourself. My picture unfortunately is not with me on the grounds, but in that classic ID badge look there. But yeah, let's keep on
Well,
going.
and Devinder, I would happily trade my bleary COVID eyes for your happy I'm getting a picture taken eyes, frankly, hands down. And I think one of the things that is when you're going to talk about ultrasound, you have to remember why you're doing it. And for Devinder, myself, and hopefully for all of you, why you're doing it is again shortening that time to knowledge about a patient in front of you, having the power in your hand learn something about the patient that you can make a decision. And sometimes it's surprising what you learn. Sometimes it doesn't change much, but it's the act of being able to do it and having that reflex that I can look. Because all of our world, this is one reason that when that machine showed up, I said, I got to use this because this is our world with clinical exam. We see tons of patients, most of them, you know, they're pretty stable and they might have something they're interested in finding out, but by my exam, I'm woefully inadequate and not a personal condemnation. It's hard to say what's going on with patients by exam alone. Davinder, this is your world, right? Like things are
It can
not
be a little
quite as
more rocky.
nice, a
Yeah,
little
yeah.
rough, critical
But
care.
to your same point of just by looking at the surface, yeah, you may know something's rocky, but you don't know what's causing it and what's underneath, right, Peter? And
Yep.
we want to the
And
value of
so
ultrasound.
at the
Sorry, go
value
ahead.
ultrasound, you're picking up a probe, and sometimes what you didn't think was there
There
is
it
there,
is.
and it just changes what you do. And so the basics of ultrasound is that when you get to that sweet spot for any application, this is what imparts in your clinical practice. And so, and it gets difficult. This is not intuitive. I was talking to a colleague today. He was talking about how that it's easier to figure out how to, fix a garage spring than to figure out what an ultrasound image is. It can be a challenge. But so the goal today is talk about a little how we simplified it and how just basics of simplified scanning to just get down and have it be successful. And one of the things which is really important about point of care ultrasound is we're not radiologists. I don't do comprehensive imaging. I've gotten good at some images. I can do some pretty cool stuff. But most of the time in point of care ultrasound, the goal is just like there's a clinical question that you can put a probe on a patient and ask, oops, wrong direction, let's go back. And you can get a direct answer. And the idea is that the answer may not be positive, it may be negative, but I love telling my patients negative. That's fantastic. I don't see this problem. And it frames what we do. So how do you do that? You have to learn how to get a picture. And we're going to talk a little bit about different tricks of the trade for getting a picture. The other thing you have to do is then look at that picture and figure out what it tells you about the question you've asked. And over, it's easier to learn normal. Positives become hard. So don't get daunted by, I'm not going to know what to do when I get a positive. Most of our patients, so it's 70%, the studies are normal. And that's so powerful. If you get a positive and you're not sure what it means, you're going to get there by comparing your positive to some diagnostic images if it's available to you. But that's a longer journey. But the power of normal, like somebody has belly pain and they have a normal aorta, bang, that's off your differential. Go ahead and do something
Yep.
else.
Peter, I
Eh,
mean, I think, oh, go ahead. Yeah,
No,
finish the
go,
last part
keep,
here.
you're on it.
I,
Go.
I think you're absolutely right about the fact that, for anyone out there who's just starting, and we encourage, please, we're monitoring the Q&A, ask any questions along the way here. We're going to do some basic orientation slides to get everyone kind of starting off, and then maybe do some live scanning, Peter, if that lends itself. And then please feel free to ask any questions along the way here. This is, again, for you guys to really feel how you kind of take your first steps. And what you just showed there about those first steps, I remember that first step of learning how to get basic acquisition skills, right? And that was a struggle. And then feeling confident about that, that's a win. But then the next hurdle is actually interpreting. Now you've acquired images, but now figuring out the interpretation level, that's another hurdle that you do. And then finding that clinical application of how you integrate that into your clinical care. All along the way, it's, there's those steps, but staying specific and focused is probably the right approach.
Yeah. And I think this last one, the application, that definitely seems hardest for everyone. How many courses where I've had repeat coursees coming and saying, boy, I love doing this stuff, but I'm by myself in a clinic. It's hard to go from of what I've learned to actually making that decision with my patient. And again, focus on normal. When you get the positives, they are amazing. And this is something which becomes part of your practice as well, that you can actually diagnose positive things to interface with. But that's a little bit of a longer journey, and it just grows. And ultimately, right? That probe is power and you can do so much stuff and you just got to run up the stairs a bunch to get there. So let's talk about ultrasound. And I think the most basic thing about ultrasound is that it's sound waves. So when you look at an image, it's sound waves that have been shot out of some transducer. It's bouncing off a bunch of stuff in the body and it's bouncing back to the transducer. And then the data processor is making a picture and like, what does all this gray stuff mean in the picture? And that's really the basics is how to just learn what that picture is. And the hard news in earlier courses that we taught and we practiced with is that sound waves aren't all the same. And depending what you're doing, you need a different shape, a different frequency. And it became really confusing just even think about what probe to use. And so most of you, I assume, have one of these or have something like this. But one of the beauties about using a probe like this, where yes, it does phase array, yes, it does curvilinears, all those form factors that you need, you're not picking it. You're thinking constantly about patient care. It's what's the problem in front of me? Is there a preset that I can use to answer the question? Have I learned an application that I can put the probe on? And you start with one and you get good at one, and then it's two and three. And so once you take a probe, uh, it's always nice to think about being more general to specific, or don't get mired in too much stuff. I always like to think about it like, let's say you're going to a cave and there's a treasure and you have a flashlight at the entrance and you want to find that box. Unless you shine your flashlight in the box, you're not seeing anything. You're seeing stalactites, stalagmites, bat guano. But if you want to see the box, you got to point the probe. So one of the first basics of scanning is the concept of window shopping. Davinder, have, anatomy doesn't necessarily translate. Like the things aren't necessarily where they're supposed to be.
But they're supposed to, absolutely right. Yeah. But it's a starting point. And to your point, the value of thinking, I love that analogy, Peter, of just saying, yes, a flashlight approach. That's really what this gives you, right? It gives you that flashlight ability to see inside the body. You just have to learn how to maneuver that light and see what you want to see, right? And finding that one use case of saying, okay, maybe that one organ plane, I'm going to look for that, identify what that looks like on an ultrasound image, build from there to your point of going with one, two, three, taking a targeted approach and being, giving yourself grace along the way as you start scanning yourself and others, knowing it's not going to be right off the bat that you're going to get everything. But you'll see that there will be these points of wins, and we'll demonstrate that later during the session about how you can achieve those wins to really kind of solidify your interest and continue to grow.
Yeah, one thing about so scanning is mostly fine motor control when you dial an image, but you got to get there. So initially, that window shopping is just move the probe. If you don't see the structure, it ain't there. Go find it. And something that's really important is recognizing anatomic landmarks. Like so many times, I'm trying to find something, I might not find it, but I can see what's nearby, and then I know I'm right. So a liver, a spleen, a uterus, vascular, those structures are so good because once you're there, it's like, okay, I got this. I know there's a gallbladder nearby. I know there's a kidney. I see the anterior vertebral body of the spine. I know that there's an aorta someplace off that vertebral body, so at least I'm oriented. I can dial it in. So you find those anatomic landmarks, and you find that structure that you're looking for, and it may not be perfect. That's fine, but you just got to cone in on that. And then once you get the sonographic site, the target you're looking for, then you start moving your hand around, and you dial it in, and you can get that yes/no finding on it. So let's talk about just like what's
How to
the
start.
right. Well, like to me, one of the most basics, it's not necessarily intuitive, is just anchor your hand. Hold the probe low. I always talk about doing the ultrasound handshake. When you see people scanning with that probe, like the dirty sock, right up
Yeah.
here, right? It's
Yep.
hard to control the probe, and especially cardiac imaging. It's so challenging to get some cardiac images. And when that probe is sliding and moving, you just feel defeated. So I like to, if I'm going to scan the heart or the arm, I'll say to the patient, hey, I'm going to scan your arm. You're going to feel my hand in your arm. So there it is. And I just take the probe and chuck it in. And now I have that nice fine motor control. I'm anchored. Patients actually really like that skin contact. It's comforting. A stethoscope doesn't do much, but when they feel your hand on the chest with the scope and they breathe, that's a comforting. So the ultrasound handshake is a super comforting thing to do. And Devinder, I think since you scan hearts, you can elaborate on this one here.
Yeah, the tip here, well, yeah, as this is scrolling through, pressure, pressure, more gel. You need to make contact. Your goal is to try to get the ultrasound coming out of here to not get wasted before it even gets inside the body, right? And how do you prevent that from happening? Pressure and gel. Be okay with the fact that yes, this is going to be something that you're going to have to be able to put a little force in. And as you start scanning yourself, you'll learn the amount of pressure that you have to get to be able to achieve an image. And you'll see what happens when you let go of that pressure, what happens to your image degradation, right? So you're really, again, trying to optimize that ability to get the most ultrasound into the body to be able to produce the best picture. And Peter, just another comment, going back to your other comment about, I love, the idea of leveraging resting on the patient. It just warrants repeating because so often, right, we see people taking, like, I often say, like, you're not trying to paint a wall, right? You're not trying to paint it. You're trying to think about painting, like, a frame, picture frame or something like that, where you're actually taking a fine brush, holding it like this and leveraging your hand. No one's going to want to hold like this and do these broad strokes because you're not looking to just do a massive screening. You're looking to make these fine motions to see specific anatomy. And that means you have to hold it close and hold it like a pencil and then hold it like really leverage the ability of holding it onto the patient. Don't be uncomfortable with that. Peter, I echo what you said about actually in my experience as well, when you actually have your hand on the patient, that experience actually solidifies the value of ultrasound to them because again, it gives you that contact versus something like that's more foreign where it's just kind of another stethoscope kind of like application. So
Yep.
yeah, key points.
And, in terms of pressure, especially when we teach cardiac scanning, like I know I'm not supposed to touch the probe. Mike Stone is probably simpler yelling at me about that. But how many times somebody's struggling, they'll be trying to do a parasternal long, and I just take my hand and I just push down. And the image becomes beautiful. And patients are really wonderful colleagues. And so when I'm scanning, I joke around with them, right? If I'm doing a subxiphoid, I joke, "Hi, sir, you're going to feel me take this probe and try and push it into your left shoulder." And they're like, "Oh, you were right." But I tell my patients, I'm going to push really hard because I want to get a picture of your heart and ask them to tell me if it's too hard. And most of the time, they're like, that wasn't so bad. And you get a really nice picture. And I think people are hesitant to do that. The other thing that is always a challenge for learners is the concept you're taking a two-dimensional image on a three-dimensional object. And like you look at a screen and it doesn't quite make sense sometimes, right? So that was a cylinder, and long axis of cylinder is a rectangle, and short axis is a circle. Like I don't know what to do with that. And so it's really very simple about ultrasound imaging, right? There's a two-dimensional beam, which is kind of you're not looking at. Your eyeball is going through that two-dimensional beam to see its long axis. So you're seeing that fat triangle to depth or whatever your depth setting is. And then images are all the same, right? You go from the top down, there's skin, there's down to the bottom of the heart. If you're doing a shallow object, make sure your depth is shallow because that's what you're going to see your object. Every ultrasound system has gradations, and they all have the dreaded dot. And to not get confused, the dot is just telling you that the screen image is matching where the dot's pointing from your probe. So in this case, it's a cardiac image. I use the dot to the patient's left. The dot here is on the left. This is the left ventricle, only because I can say the dots are are matching that orientation. So if you get confused what you're seeing, take a break, say, okay, my dot is pointing here. There it is on the screen. That's head or tail, that's left or right, and it becomes really intuitive. And once you get the picture, then you dial it in. This is the fun part. There's not a heck of a lot you can do with a probe once you get your image, right? You can, again, put periodic ingestion, you can slide, you can rotate that two-dimensional beam to get a long or short axis. Rocking is kind of heel-toe with that two-dimensional plane like a flashlight. And then there's fanning, right? This is the basics. And Devinder, what do you think the image is going to be like from this picture?
Not the best.
Not good. And if you're scanning and you're not getting a great picture, like I don't get it. I'm on the right spot. Take a look at your hand. I know we always talk about look at the screen and just what you see on the screen. But if your hand is at an angle, there's a couple of reasons you're getting a really bad picture. And this is common, right? Number one, you need to have a really good interface of probe to skin with gel. And if you have an angle, I can guarantee there's some air in there and it's a degrading image. So you're getting a bad picture from air. But just from basic physics, an angled probe doesn't give you a good picture because yes, there's going to be some scatter off your target back to the probe and it's going to generate an image, but not a lot of ultrasound beams went back. Most of them went out because that's how waves and ultrasound waves work. And so there's some Martian dudette or dude saying, whoa, cool kidney. but they're not taking care of the patient. And the image you're getting is worse than what they're seeing. So if you see your probe at an angle, a simple trick is just slide to that probe and rock that probe or fan that probe so that it's perpendicular over the target. It's a simple fix, but it changes your image quality because now all those ultrasound beams are coming right back in at you, and you get a fantastic picture when only a minute ago with that angled probe, it didn't look so good, and it's incredibly frustrating. And it's hard to make decisions when your picture's not good. So this is fanning back and forth, and you can imagine a flashlight beam coming out of that probe, just in that two-dimensional plane, just fanning through. You use that to just get that sweet spot. And this is an example, Davinder, we both love this picture because this is a juicy median nerve.
Beautiful, beautiful
Think
nerve.
about the needle you can put in that thing. But watch what happens when I fan the probe, right? If I fan off that nerve, it becomes dark. If I fan off the other side, it's not just the nerve, the entire image becomes junky. So for the nerve, that's anisotropy, but for the entire tissue, that angled tissue gets worse. And so get that perpendicular probe. Here's that median nerve. Here's another thing that happens when we're trying to teach in QA. What do you think about this picture? Do you like it?
I don't
No.
see much, right? Yeah.
Yeah, it's the same thing. That's the same picture. That's my wrist. How about this one?
Same thing. Don't see too much, but the other way, right? But what is
Yep,
that?
it's overgained, right? And so simple thing, what's great on the butterfly, it's got an easy use, right? So you go ahead and you take your finger and you swipe it back and forth on the screen and just adjust the brightness, right? It's called gain. It's just really how bright it is. And you get the brightness that you like that matches what you get confident in. Similar,
And
this is a wrist, right?
Peter,
So
I'll
this,
just
oh, go
pause
on.
right there
Yeah.
for one quick
Yeah,
sec. Yeah,
sure, of course.
on that concept, I do want to work like what your view of an ideal picture is going to be variable across people across care environments. Right? If you're in a very bright room with spotlight and things like that, you may have a different gain setting versus if you're kind of in the corner somewhere, with less light. So and that's always something to recognize, and even our own eyes, right? What I find to be the optimal gain setting versus what you find to be the optimal gain setting could be a little bit variation there. But ultimately, you find the happy point. And I think your point about realizing how do you is well, it's a gain function, right? You want to adjust that
Yeah.
ability to see how well the image can be improved or degraded based on adjusting the gain. So just know that that functionality is always there. Butterfly makes it super intuitive by just sliding left and right and finding that picture that makes you resonate with what you think is going to be the highest quality.
Yeah, and frankly, on ultrasound systems they can program, there's something called dynamic range. It's how much contrast you have, and everyone's different. Like you and I don't like the same contrast in our images. And what's actually really cool about the butterfly for all of you scanning, sometimes depending on the patient's body habitus, their tissue density, um, are you might not like what you see for a setting. For instance, I actually love using a nerve setting for some of my vascular work because I just like that contrast. Um, And so what's nice about the butterfly, there's lots of linear array settings. And so if you don't like what you're seeing, they'll change it. Go from MSK to soft tissue to vascular access. They all look different. And one may make you feel better about what you're seeing. Same thing with curvilinear. In cardiac, you can tap the screen and cycle through a couple different ones. And you kind of change your dynamic range and the way the probe is set up by our awesome engineers and sonographers. But there's one that you like better. And because you like it better, it's the perfect setting for you. Someone else might not use it. Looks like
Right.
there's a
Peter,
question.
yeah,
Yeah.
we got it. Great. Always love the fact that, again, please keep them coming here for this session in particular. So the question is, how does that perpendicular principle apply to the subxiphoid view, where we are angling a probe so sharply? So interesting question. Peter, if you want to, yeah, go ahead.
Sure. So I love subxiphoid, and it's a great question. And subxiphoid is really challenging. Oops. We'll move on to that in a second. I'm just trying to get this out. So on a subxiphoid, the issue is if this is a xiphoid process, you're taking your probe and sliding off and you're angling it and you're looking for the heart that's someplace over here, right? And so the challenge of a subxiphoid view is exactly the issue of trying to get those perpendicular beams to the heart and bouncing back. Because if you're getting only some image waves there, you get a really muddy image and it's not very clear. So this is again back to the concept of and pressure. If you start on the xiphoid process, instead of in the belly here, and you start here, if you pop that probe off and push down and up, what you've done, you've bent the skin and you've sealed that gel on the skin. You get a beautiful seal. And now it's the idea you have the hand on top of the hole. You try and get that probe as flat as you can
Yep.
to see the heart. And what are some things that
And
happen, Davinder? Someone doesn't have enough depth, so you're not seeing the heart because it's too far away. So get a lot of depth and try and get that probe shallow. And what are some of the tricks that like, and you may not do it. So there is a way to get that angle better. The simplest thing is have your patient breathe in for 10 seconds and hold it for 10 seconds. What that does, that takes that heart and it pushes it right down to the xiphoid process. And all of a sudden, instead of having that really shallow angle that you're not seeing much, you have this beautiful steep angle and you're getting much more wave returns to probe. And it almost looks like an apical 4 sometime. Davinder, other
yep.
things do you think about with
No, I
that?
mean, I was just going to call out, I love, how you described it, right? For the attendee asking the question, look what you just did with your hand there, right? When you start off and you're feeling that subxiphoid, the goal is to go just below that to be able to get that point and make the impression in the skin. Again, we're
Uh-oh.
going to be a little risque here, and so I know it's already started, Peter. So, like, watch what happens is when as I go in, what's happening to my probe? Well, it's actually becoming more and more perpendicular to that skin, to your point.
Right.
And then it's that fanning process to be able to leverage to what angle you're getting to be able to shine the probe to the heart. And we'll talk about that, like the strategy of what you just described. How do you get that flashlight to now shine to the heart? But the very first, the principle still applies that you are trying to get actually perpendicular still. And that's how you just make it with your force, right? That's also why for the subxiphoid, you don't want to really learn. This might be the one time where we don't really talk
That's
about
right.
holding it
Don't
like a
hold it like a
pencil,
pencil.
right?
You're going to
Because
fail.
you're going to minimize that angle and you're going to have to put the probe, your hand on top. Again, maybe that one time where you're going to use that broad brushstroke approach, but that's because it'll allow you to do this, right? It'll allow you to push in to be able to get that probe into the spot that you need to. Great question,
And
and please keep it going. Yeah,
I'll add a couple of things. So tricks of the trade. Make sure you have adequate depth. You can always cone it in. Again, general to specific. General means when you start scanning anything, make sure you have enough depth. You can always go, holy crap, it's only 3 centimeters versus 15 and dial it back. But if you have your heart at 20 centimeters and you're at 15, you're never going to see it. So you can do anything you want, and your probe's never going to have that perpendicular beam to the heart. Number two, again, don't start in the belly. When you slide up the belly, you usually stop at transverse colon and there's gas and crappy image. So pop off that xiphoid process, push down and up. And that's when I joke about my patients like this, you're going to feel this. And they're like, ooh, but you get a great picture. The other trick, which I always like to emphasize, is when you ask your patient to hold their breath, do it yourself. Right? I can't tell you how many patients I've scanned where I said, "Can you please hold your breath for 10 seconds?" And of course, I'm nerding out at what I'm seeing, and I look over and they're turning blue. Right? So I now have learned to nerd out while I'm holding my breath and stopping. And the final thing, if the patient's conscious, have them flex your legs. That'll relax their belly wall. It's easier to get down and get that image. So great
yeah,
question. And please, other people, we're happy to go over any
keep them
application
coming.
you
Yep,
like. So
yep.
Devinder, I advanced it, and here was the same wrist. This is a wrist. What do you think about
Same
this
wrist,
image?
same.
Do you like it?
Where did the no? Where did the nerd go? Right? Like it's how did the and go
That's
ahead.
a
Yep.
nerve. It's at
Oh, there
one
it is.
centimeter, just like this one. What's the problem?
Wasted ultrasound. Wasted ultrasound
Wasted
because of the
ultrasound.
depth. Yep.
Again, the ultrasound systems are most accurate when you have your target centered in the middle of the screen. This is at a 5 centimeter depth. This wrist is only 3 centimeters. So 2 centimeters of ultrasound technology has been wasted on doing artifact off of a table. So a simple thing to do at the bedside is just, and everyone forgets. So my settings, I remember my last setting. So um, optimize the depth. Remember, like, oh my gosh, like I'm looking, I have all this real estate down below. It's not helping me. And on the butterfly, you just swipe up and down and, go ahead
Yep.
and do that. So,
And
Devinder,
really,
oh, go
well, I
on.
was going to say something for superficial structures, a big, such an improvement in image quality, right? If you're looking at
Oh,
something like, say you're doing a vascular access procedure or looking at anything at, around 1 centimeter, defaulting to that going from that 4 centimeter to 2 centimeter change in depth, dramatic improvement in image quality. But you have to think to do it, to your point, because you may just kind of think, oh, I see it, but if you really are trying to optimize that picture, just roll down that depth, and you'll be really amazed about how the image quality can improve.
We have another question on gel pads. Do you use gel pads?
I no, I don't really use gel
Uh,
pads. How about yourself? You
I
use it sometimes
love
for
gel
gel
pads.
pads?
Yeah, so a couple of things when you're scanning a shallow structure, there's some th tricks you can do to make your scanning better. If it's a hand, you can chuck that hand in a water bath or a foot, and you can see just beautiful image. You can even see
Beautiful.
that
Oh my
whole
gosh.
flexor pulley
Yeah.
systems.
Yeah.
Not so good for procedures. So that's when a standoff pad is really nice. So the issue when you're scanning something shallow, especially if you can't put it in water, if I can't put a like some leg thing in water, the standoff pad just backs off your probe, so you can get that sweet spot in a soft tissue or linear raised setting where you get the target in the middle of your field. And I actually do that for procedures. I will hold the probe at the end of the standoff pad so I can see where the target is, and I'll come in with a needle and I'll catch that needle below dermis. I'm not going through the standoff pad itself, but I set
Yeah.
everything up. So to the question of a gel pad, if you can get them, I don't. How often do I use them? I love having a case of gel. Case is what I think you buy them by 10. They're really nice to have, and they're for those. Depending on your circumstance, if you have a really shallow structure that you really want to get some better detail on, I've said really twice, bad English. Those gel pads are fun, and so I
Yeah.
love having one. If you don't have one, you can use a 100 cc bag of saline. There's other things you can do to get that distance. The nice thing about the gel pads is they're rigid, they're rectangular. I mean, they have an edge, so if you're doing a procedure, I have a harder time using 100 cc bags of saline because it's hard to get around that edge when it starts collapsing. So, and if you go through the saline, it kind of leaks. It's bad, bad. Anyways, um,
Yeah, no, echo your points, Peter, about the gel pad is useful for procedures, especially very superficial biopsies and things like that. I think, um, in my arena, not often available because of, sterility and trying things like that. So we just use a heap of gel and try to hold that probe lightly. But I do want to go back to your point of, yes, the value of for the learner. For anyone who's wanting to kind of I remember the biggest delighters was the first time I put my hand in just a little plastic box of water, put the ultrasound probe, and the visualization you got, and the amaze that I got about seeing, wow, dynamically, the amount of you can see your joints, you can see everything. It's phenomenal, the image quality you get, and it really resonates the ability of like, wow, the power of ultrasound. When you're able to harness the ultrasound to get to the area it needs to, you can get some dramatic images. So I encourage anyone who's trying it out for the first time, put your hand
it's
in some
fun.
water.
It's
It's
cool.
fun
It's
to try
fun.
it out. Yeah, yeah,
And Davinder, I know that you don't typically send your quality critical care hours looking for splinters, but I have to say that back to the gel pad, looking for a superficial foreign body, it is ah. And so you chuck them in water and you look around and you can see so clearly. And then if you know it's there, then you can take it out of the water and now you still have it framed and you can, but it helps sometimes. Again, these are small diagnoses, but it helps it happen.
that's great.
Anyways, you want to try some scanning? Should we do it?
Let's do it. Let's
All
do it.
right.
All right. So
What are we starting with?
So I thought that it would be starting with looking at right upper quadrant, right? And the idea, it goes back to what, how you set the tone of saying, hey, let's leverage when you're new to ultrasound imaging, we all have received, our anatomy skills and know relative where things are. We all know the liver sits just under the diaphragm here on the right side, and the kidney is below that. So we know it's generally in this space. And the beauty of
Yeah.
ultrasound imaging is that of those organs, because they're solid organs, they kind of look like the anatomical representation of what we are used to seeing in the lab. So thought we'd just start with that, Peter, if that sounds all right.
Yeah. And I think one of the really cool things about, as an example of scanning anywhere, is as we'll talk about and show, sometimes being in one spot doesn't give you the answer you need. So you have to be prepared to see your target, but maybe move to a different part of the target. As in when your colleague is trying to palpate a liver edge and you just say, here it is over here. It's like, come on. Anyways, all right.
Another
I have
another
some graphics as
random,
well.
great. Yeah. So I'm going to, if you, Peter, I'm going to start sharing my screen here to be able to show the scan.
Fantastic. And please, those of you who are listening in, please, um, anything we can be helpful in discussing, we'd be thrilled to
Yep.
banter about.
That's great. Peter, if you don't mind canceling or stopping the
Oh,
share. Yep.
yeah, I can do that. It's all
One
you.
one tip as well, like I'm just going to show that I don't have ultrasound gel here in my home. Surprisingly, I'm out of it. So easy way to make do is just some standard hotel lotion that you pick up anywhere along the way, right? Works pretty well. Hand sanitizer works as well. Oh, we have a
And
question here about
and the other
yeah,
thing I was going to say, what's cool that's coming down the pike. There's some companies now that make these pads, so you don't have to use gel anymore. So I know
yep.
Cifco makes, you can flop a pad on a patient. You can spray some patients. They have these new products that are, especially for procedures, make it a little less clunky in terms of needing gel, and they help with some of that interface. Um, but you have your setup. Let's do this. We'll answer those questions. Why don't you go ahead and
Oh, sure.
I've
Yeah.
always wanted to
I'll
see your
just,
liver, Davinder. So this is going to
all
be really
right.
fun.
Here we
Yeah.
go. So let's start off first. Like, okay, so I turned on the butterfly device. I put on the app, popped up, and I already, just from the basic overview you provided, one thing I noticed is look at the here, let me get that video off. The or matrix of the ultrasound probe, right? It's I see cardiac CARD at the top, tells me it's a phased array. I see that tiny little footprint. So because I went through your course, Peter, and learned the different types of probes, I'm gonna automatically know, wait, I'm looking for an abdominal structure. So this is probably the wrong preset. So I'm gonna go change that, go to abdomen, and then boom, watch what happens to now I see a wider area at the start, looks more like that curved linear array.
Yep. And it's
And
more
now I'm going to
gray.
start, yeah,
And I
and
have a
the gray
question
scale,
for you.
yeah.
What's your clinical question, Devinder? What are you trying to answer?
So I'm looking for, that's a great question. And I would say first step is I'm looking to see if I can identify from the kidney. And with the protection of knowing I've heard something called the FAST exam, understanding the idea of like that's used in trauma to evaluate for free fluid collection. So that's my area of focus is to try to learn that skill set. And Peter, like feel free as we're scanning, how can we use different areas of that and to adjust to look for different clinical questions? And so,
Yep.
all right. So I'm going to know that, okay, the liver is somewhere around here. It's going to get a little risque for the evening hours here, but here, I know round mid-axillary line. I'm going to place my indicator here, right here at the top to know that I'm going to have a vertical ultrasound plane from here. And I'm just going to place the probe here and try to find what I think looks like my liver.
And
Peter,
there's liver.
there's liver.
And frankly, one of the cool things about where you put the probe, like this is just a fast lesson or a CITES lesson, is you're right at that inferior pole of the liver. So you're way down, which may be hard for you to get higher up, but that's where you look for blood. I think people get trained in the right upper quadrant to look at Morrison's pouch. Eh. The more sensitive view is that inferior pole of the liver. If you can get the inferior pole of the kidney, usually it's obscured by bowel. So this is by chance, right? You've done a right upper quadrant where you can see that anatomic landmark of the liver. If your question is, do I have free fluid? The answer is no, because your ultrasound finding would have been right down by that inferior pole. So if you have other questions, like you want to see the kidney or you want to see the diaphragm, what would you do next?
Yeah, so that's why I'm looking at this picture and seeing, okay, I see liver, but I don't see the kidney. Well, I know kidney is a, retroperitoneal structure, so let me look at my ultrasound probe and see what is that angle that I'm having, and do I need to fan my probe to aim my beam more posteriorly? And so watch what happens when I do that.
There it is.
There's my kidney popping up.
You at least
And
have a right kidney, Devinder. And you don't have
that's right.
hydronephrosis, right? So if your question changed, like, the abdominal exam is normal, I can go to kidney and there's a beautiful kidney and there's no hydro. Fantastic. Right. And so that's the idea is that you can just change your probe position and know where you are and start finding something else that's in the neighborhood. Um,
So, and this is, I think this is a great view to practice that whole manipulation of fanning, right? To be able to see, I'm going to go off here, Peter, for a second, just to kind of talk about it with my hands. That ability of knowing, okay, if I use my ultrasound probe by just fanning, oh, I'm seeing more anterior superficial structures versus more posterior inferior structures just by making that manipulation. It gives you that point of what you're doing with that flashlight, right? Being
Yeah.
able to shine and aim and see, and it connects to where you know the anatomical regions are of these different organ systems. So, again, practicing that I think is a great starting point first, just to kind of get familiar with all of those concepts.
Yeah. If you want to unshare, I'll do a really quick a couple slides, and then we have a bunch of questions. So I'll go real quickly and just gonna focus on that concept. So I'm going to share again, and let's do this. And this is, hold on, where the heck did everything go? All right, everyone can see my mayhem here. Unshare. Hold on a second. Something
As you're
is
pulling
happening.
it up,
Yeah,
the
my
question
screen went
about,
black, so I'm just going to
oh,
talk. I can't see a screen anymore.
all right. Well, as the first question about is butterfly safe to use underwater? Is the whole probe water resistant? The answer is yes. It is submergible. You can be able to do this and scan through to the top here. But what is the best setting for facial aesthetics? Looking for arteries, nerves, etc. Um, I would answer that. Depending on your preference. We do. There's a superficial mode there that you are allowed to be able to get to 1 centimeter. Peter, do you have a preference on which
So
particular one?
we have the vascular superficial that was specifically built for doing facial injections. So there's the Doppler is optimized to see small vessels, so you don't inject new vessels. So that was designed for it. I personally like uh, the other soft tissue settings better, and which go to 2 centimeters, and you can adjust your depth. Um,
Yeah,
Again, it's preference. The vascular superficial has a little bit of a lower dynamic range. It's more black and white. I like a little more grayscale. Here I am liking dynamic range, but not for face. Um,
yeah.
there's another
And I would say
question.
for
Oh, go on.
color there, well, just a comment, if you're using color, that's where it really pops to be able to potentially use that vascular superficial to see the value there.
And and just a lesson on color Doppler, when you if on a superficial Doppler, oftentimes you'll get what's called aliasing because it doesn't take a lot of energy, so those little vessels. And you'll see if you see sparkly, again, the nice thing about the butterfly, once you have Doppler turned on, you're sliding your finger back and forth on the screen, and you can control the intensity of the Doppler signal. And especially for facial injections, typically you'll get some aliasing, we get a lot of speckling. Um, there's another question about cardiac scanning. IQ plus image gets small when in M mode. Yes, and when you have your screen split, and if you're using a phone or something small, it's a tight screen. Um, I think if one of the ways that we went around that problem in our workplace, we would use iPad minis just to have a little more. Yeah, you can use I mean, iPad is not the most convenient one when you're working, running around with patients. But that's an issue. Anytime you do a mode where it splits a screen into two, for any of the handhelds that you have a smaller screen, it makes it a little challenging. And question about mineral oil, whatever works is the
Yep.
answer. We've all been creative. One of the things, all of the handhelds that have a battery in them get a little warm. They all do. And so one of the things, a reminder, when you're scanning, you say, boy, I had a great image, now it looks awful. You might have just cooked some of the gel off a little bit. So I guess it's as someone in a first world setting where I have gallons of gel. I bathe people in gel, which you can't necessarily do when you don't have it. So the answer to your
Yep.
question, we try everything out, and that's you just got to be resourceful, and the goal is to get the image. I've scanned with saline. I've just poured water on people and get scans. They're not great, but I've gotten some good images. A
Yep.
real quick share. I'm back to figuring out what happened with my computer or not. So let me go back to here. And just reiterating what Davinder was doing with his self-scanning, and we'll talk about right upper quadrant. One of the things, again, about where are you pointing the probe, a lot of people will be, and you get trained there. You go mid-axillary and shoot across, or you stand low. I actually find my success is better when I take that probe and I pull it out to around 10 o'clock, or I guess on this side, this would be 2 o'clock, if you think about the chest as a clock face, because I'm pointing my beam down. And if my goal is to see fluid, there's so many ultrasound applications where fluid controls your scanning. And I want to be accurate seeing fluid. So the lower I'm looking with that probe, the more likely I'm going to see it. That's where it flows. And so back to sonographic landmarks, this is a little bit different of a right upper quadrant. And there is the start of a right upper quadrant for myself in a trauma view. There's that anatomic landmark. I love liver tissue or splenoides, so that vascular tissue, homogeneous. It's beautiful. And you can see to the left, there's a diaphragm and there's the spine. So initially, when I'm doing a trauma assessment, one of my questions is there any fluid in the lung? So I start out, I've got my landmark, and I'm going to look to the left. Like I'm not even going to look down where I want to look for fluid in the abdomen. I'm looking left. And the idea is that I can have normal versus abnormal, where that spine is now is visible because there is fluid to the left. All right. But if my goal is to also look for fluid in the belly, again, this is Morrison's pouch. There's the right kidney. That's a great landmark. There is a little bit of Gerotis fascia, a little fat in there, but that's not where you're going to see blood. You're going to see blood over here and over here. So you have to slide that probe down to get to that distal part of the liver if you want to be truly negative. And so in a right upper quadrant, the idea, I guess I missed the slide, is, well, I don't know what happened here. We'll get out of here. But the idea is to start and slide downhill to get that
Yep.
distance from the diaphragm, and you just move your hand. And for lots of scans, you may not be quite in the right place. You may be seeing something, and that's back to the concept of you got to move to where your target is, and you got to move to where your finding is. And right up quadrant's a great place to practice that because you, wait for once you get the trifecta, you go doink, and I see diaphragm, liver, kidney, and inferior pole in one shot. I'm like, this is great. Usually you see something, but you don't see everything. And so the good news is you control a probe and you can put it any place you want to dial in that picture you want. So that's a great application to look at.
Echo all your points, Peter, and I think that sets a good tone for kind of any type of exam you're doing, right? That you will learn one right upper quadrant view, but then you have to layer in the clinical question you're asking because, yeah, you just slide up a little bit higher to be able to look for pleural effusions, right? Or to your point about looking for other aspects. Similarly, if you're looking at gastric ultrasound, there's a technique for that you have to adjust to optimize to make sure you're seeing not just the antrum of the stomach, but I mean, not the fundus of the stomach, but the antrum of the stomach, right? So as you get in your layers of training, you get exposure to first placing the probe, seeing the anatomy, and then layering in that skill set of like, what's the clinical question you're asking to be able to adjust your image. But starting with those fundamentals of what you need to do to optimize to get to that next stage, I think right up quadrant's a great first place to kind of start because you can see it real time how all that's happening.
I was thinking as you mentioned gastric, one thing we didn't talk about is you can move your patient, right?
Yeah.
So, because when you anesthesiologists are doing gastric ultrasound, you're putting your patient on their left side, right? Because that makes the fluid in the stomach bomb down towards midline, and it makes it easy to see the pylorus and that area of the stomach. For all of you who want to scan a gallbladder or a heart, trick of the trade, roll your patients on their left side. Sorry, you're on the right
Yeah.
side. I'm on the left side.
Yeah.
Because
Yeah.
that's back to fluid and gravity. Fluid gravity will pull that gallbladder down to the bed. You get this. It's like one of those party balloons in a kid festival, right? They stretch them out. You'll see the gallbladder when you couldn't see it before because it's all over the place. You don't know where the gallbladder is in somebody's body. It's not Frankie Netter. And cardiac, oh my gosh, you take that big bag of water and you pull it to the floor. You get a super parasternal long. You get a super apical 4. It just makes life easy. So roll your patient. If you're not seeing what you want, maybe their patient position will change what you see. So I move my patients all the time. We're jostling around.
Yep.
There's a question
Peter,
for you,
you
Davinder.
triggered. Yeah,
Yeah,
absolutely.
gastric content. That's your
That's
purvey. I
what
don't do that
that's
stuff. I just put tubes in.
yeah, so but you're absolutely so you already answered like the great point of for gastric ultrasound is to kind of layer it in. You want to do an exam where your ultrasound probe is vertical placed, similar to if you were doing an IVC around the area where around approximately 2 centimeters below you were traditionally where you would place the subxiphoid view to look at the heart or IVC. You're looking for that antrum to be able to see the liver. If we have time, I'm trying to be mindful to make sure we get the questions. I'm happy to do a demo scan. We have some videos available on this as well, but you want to place it here scan right here. But the key patient position is you don't want them supine, as you just said, because you can have
You just see
you can have a
gas.
false, yeah, you can just see gas, and you may have a false negative. You go there, even if you're seeing the antrum,
Yep.
it may look completely collapsed. But that's because that food, if it's less than 100 mLs, is layering across the fundus and hasn't made its way to the antrum because you haven't motivated it to be there. And so turning them on the right side to be able to get that view is the key thing to be able to do. And that's what all the studies have shown to have over 90%, over 97% sensitivity and specificity for detecting greater than 25 mLs is when patients are on the right side. And
It
incredibly
is so
powerful
cool.
tool to be able to do it. And again, the GLP era, right? This is a hot topic for anesthesiologists, especially as guidelines and recommendations are changing almost every 6 months or so about what you should be doing for the medical management perioperatively. Incorporating gastric ultrasound perioperatively is a very useful skill.
And frankly, I'll go to pediatric emergency medicine. You want to see a pylorus for pyloric stenosis? Roll that kid on the right side.
There you go. Yeah.
They might not like it that much. They'll be screaming, but you get a really nice view of that pylorus. Um, I like Motorola Moto. That's a great handle, sir,
Yeah.
ma'am. Um, so the question about the Butterfly IQ Plus can't do pulse wave Doppler and color image at the same time. That's true. The IQ3, on the other hand, does.
Yeah.
So
So,
I think, back to scanning and ultrasound. Ideally, it's nice to get a bunch of stuff at once. Um, I think the goal again is that you're answering a clinical question. So if the pulse wave Doppler doesn't give the answer, you want to throw color. Yes, it's two separate things, but um, the goal is to do what you can. And these are handhelds, right? These are not 100,000 K, 100,000 euro systems. So there are some limitations, but 99% of the time, or maybe not that much, 99.5%, they are beautiful for it. And sometimes maybe you do need to use a different system. Or I am thrilled that the IQ3 does color and pulse wave Doppler now. Like that was a fix, and
yeah.
and it was understood. And just going backwards, just in terms of data, we couldn't go backward to the plus. There's someone
Yeah.
who's
No,
had their
yeah.
hand raised. If you can,
Oh,
I guess we can either turn on audio, or if whoever has their hand raised, if they can type a question
I
in,
think,
or
yep. If you could type in your question, that would be great. And Peter, I'll just
yeah.
echo, that the last comment you made, I mean, that's why we're so excited about this, right? Seeing the journey of ultrasound technology. It's one of those few modalities where every 2 years, especially with chip-based ultrasound, it is just getting better and better and better. MRIs aren't getting better this much faster, right? CTs
No.
haven't changed forever. But this is
And you
the
ain't carrying no
space that,
MRI in your
yep,
pocket, Davinder. I'm
that's
sorry.
exactly
Ain't
right. And
happening.
so that the really it's a great journey to see where ultrasound imaging has happened, even in our careers, from going from wheeling something that you had to like literally work out to be able to get it to that room to be able to do your scanning to now pulling out something in your pocket and being able to answer more and more questions just
Yeah.
right from something that you can do pretty robust imaging on. So definitely exciting times.
And I was thinking with the question on pulse wave Doppler, one of the things that I think is so important about basic scanning is to learn to trust your eyeballs. So, I have people approach who want to learn advanced cardiac calc packages, and I'm happy to show how to do a VTI or cardiac output. The number of times that myself in 25 years of high-level clinical emergency medicine have used the measurement, I can probably count on my hand.
Yep.
And it's not being disparaging that measurements have value, but especially as you're learning, don't get lost in the weeds. The basics are of a ton of value. Like when you learn how to look at a heart, ask yourself, am I seeing 60% of the blood getting out and about 40% left? That's normal. And you get really good at it. And when you measure, your measure is validating the fact that you're learning normal. And when you learn a lung ultrasound, you learn A lines, and ultimately, if you can tell that and figure out how to get a good A line, and that's just sliding and rocking and sweeping, that is so valuable. Then those positives come in. Question: I received my device yesterday. Basics course on your website. Yeah, we have definitely some. We have tons of tons of
Yep.
videos. Not as good as Devinder, but certainly are. And frankly, reach out. Happy to help if we can be helpful.
Yeah. And
Morbid obesity, spinal epidural puncture scanning settings. I will say that one of the tricks of the trade for me, and Devinder, I don't know how you do this, is people try and use a linear array setting for lumbar punctures and spines.
Yeah.
Don't. Curvilinear, whether someone is heavy or someone is skinny, you get a field of view and you can tell where you're going. And for the most part, we're not doing dynamic punctures. We're marking out with static. So the trick of the trade for whether someone is heavy or not is get away from that linear array setting. You
Yep.
have too narrow a field of view at the depth you're seeing the spine. Get that curvilinear probe. You can see the lamina, you can see the spinal canal. It is so freaking cool. And what's nice about marking it out, you can actually see the angle of the spinous process coming out, where you can adjust the angle of like, Davinder, this is back to us not having ultrasound. I still remember being taught how to do a lumbar puncture, and they always talked about taking the needle and going down 5 degrees. I'm like, why would I do that? And with an
Yep.
ultrasound, you see that, yeah, if you don't go down 5 degrees and you go straight, you go doink into bone.
Yep.
That's the
Yep.
sound of a needle hitting bone. It goes doink. So,
Some people will go through that, try to go through that bone, and I think your great question. Yes, you can definitely use ultrasound for, the evaluation. I
mm,
currently in my clinical practice use it for just understanding what the orientation, right, of where the spinous process is, lamina. I don't use it real time very often while I'm scanning, but just do my scan, make my marks, and then proceed with the procedure for a spinal or epidural procedure. I echo what you said about one of the fun things about a chip-based technology like Butterfly that allows dynamic preset changing is what you just said. Like if you're doing a lower extremity nerve block, uh, the value of being able to just by depth change that ultrasound matrix to be able to go boom versus like, oh crap, I needed a curvilinear probe. I'm using a linear probe. Well, break sterility, hand me the other probe, re-sterilize, do all this other stuff. You don't have to do any of that. You just swipe the depth, right? And echo your point about curvilinear is the way to go for most of those things. Um,
I
answering,
guess we're almost out of time. We can go a few more. I will say again, back to bring this back to basics. How profound. I'm in emergency medicine, so I do a lot of lumbar punctures, and unfortunately, we have patients who have idiopathic intracranial hypertension, and they get tapped a lot. And I still, again, after learning how to do ultrasound guided taps, I remember doing one. It went effortlessly. It was like textbook. And the woman starts crying, and I feel awful. I'm like, I'm so sorry. And she's like, no, this is the
relieved.
first time I've had a lumbar puncture in almost 10 years that wasn't excruciating. I didn't even feel this. And so again, back to what ultrasound does for clinical practice. It's a simple procedure. We all do it blind, and many of us are good at it, but with an ultrasound, it gives you that added sweet spot of just being great to your patient. It's such a nice thing. Sorry, I just was thinking about the case.
No, I definitely resonate in similar storylines there. Carotid intima, I think, vascular carotid is a good way to look at the carotid intima. I know, Peter, we're kind of closing out here. We're actually at the top of the hour. I think we just really scratched the surface on the value of kind of getting started, right? And I think, if I can, and then I'll let you end this off here because you did such a great job of kicking this off. Just get started, right? Hopefully, you've heard us talk about both of us were on this journey of embracing ultrasound, figuring out the utility, and seeing. And it's those cases. I always say this that it was the cases I look back where I didn't have ultrasound training, and then when I learned that skill and how I was able to improve my care of being able to diagnose that pericardial effusion that I otherwise would have missed, seeing that gastric content full of content that I would have otherwise just induced regularly, those events solidify the value, and then you on specific use cases, and then you're off to the races of wanting to learn everything else. But you just have
Right.
to get past those hurdles. For everyone who joined, you've already taken that first step about joining this webinar and embracing the value of ultrasound. Lots of online materials through Butterfly and others that you can get to get somewhat comfortable, and then just keep scanning, keep scanning, keep scanning. Right. So Peter, those are my final thoughts. I'll leave it to you to
I,
send
I
this out.
I can't help myself. There's two questions that would go really quickly. There's a question about IVC. Um, Either it's really big or it's not. Don't measure it. Look at the lungs and look at the heart. It's
Big questions.
right.
Yep.
Yep. Like don't get lulled into submission that a measurement that CVP is going to value. It's a great tool to say, is it super big? If it's not super big, and again, it's not fluid responsiveness, it's fluid tolerance. And ask yourself the
Yep.
question, does your patient need fluid? We can do this. I can do that for an hour. Um, I have to say one thing I wanted to get to really quickly as we want to do vascular access. When you learn how to do vascular access, for every probe, they teach you to do 45 degrees down to the target and pull your needle back. Don't do that for any probe. But the way vascular access is successful is you take that needle and you go right against that probe. Don't be bashful. Bang it into the probe, because the sooner you can get it to the probe and see the beam, and now with our needle offset, like that beam is right here. You see the needle when it gets into the dermis. It's sick. But one of the things that when I teach, and a lot of questions on when I'm hands-on with vascular access, number one, if you can learn how to do a peripheral IV, you can do anything. That's the hardest ultrasound guided procedure. And number two, don't do that geometries thing. Just any probe you have, obviously, hopefully this one, just get that needle against the probe, get as close as you can, pick it up as soon as you can, because you'll be more successful. This has been so much fun, Davinder. We could talk about this forever, and there's so many topics that we could talk about. So thank you all for joining. Hopefully this had value for you. And just remember the basics. Even Davinder and I, when we work, most of what I'm doing is I'm getting a basic image and I constantly have to correct my hand because like, oops, the gain's wrong, the depth is wrong, you know. But the idea is that it becomes reflexive where you know where to tone. I will close. A friend of mine, Rob Arnfeld, was critiquing my cardiac scans. You'll appreciate the Davinder. So I'm feeling like a cowboy. I got this beautiful apical 4, and he goes, Peter, if you were to rotate your probe 5 degrees counterclockwise and rock the tail towards the left side, you would have had a much better picture. That one's not so good. And I'm like, how does he know that? And now I'm teaching people to rotate the probe. So all of you, thank you for being here.
Welcome.
Thank you for being interested in using ultrasound. Scan, scan, scan. Reach out to us. We're happy to interface anytime to support you. So I think the goal of this is for you to have a network of ultrasound crazy people to let you continue your journey. So thank you so much. It was a pleasure having you. Davinder, I could talk to you all
Peter, it's
night
always great.
long.
Yeah.
See you later.
All right. Thanks everybody.